in a disaster, I think it is important to look at or to actually not to marginalize people with a pre-existing psychosocial disability, because after disaster most likely they'll be further marginalized and they do not have any access to any kind of intervention after disaster. Similarly, people without pre-existing psychosocial disability can also develop psychosocial disability after disaster. Therefore, I think it is important to ensure that vulnerable people as well as people with pre-existing psychosocial disabilities must be taken into consideration, should be mainstream in any form of disaster risk reduction or disaster preparedness activities, because this becomes a vicious cycle then. People who do not benefit from interventions after disaster in the form of being included in disaster preparedness or disaster risk reduction then become even more vulnerable when another disaster strikes. People with disabilities, whether it is psychosocial, whether it is sensory disabilities or physical disabilities, often get marginalized after disaster, and people with all forms of disability would suffer psychologically after a disaster. And the more they are exposed to a disaster, the more severe their psychological distress is going to become. And therefore, it is important, as I mentioned earlier, that vulnerable groups, including children, elderly people, but also people with pre-existing psychosocial disabilities must be looked, the needs of these people must be looked into very carefully. And that could vary from, being prepared in terms of medications, for example, with people with pre-existing illnesses or psychosocial disabilities, where in a case of disaster, most likely there would be interruption in medication, there would not be continuity in therapy, for example. So the needs of these people must be looked into. People, adolescents and children might manifest in a different way after disaster, for example, in refusal to attend school, or bedwetting in children, or in adolescents starting to abuse substances like alcohol or drugs and things like that. So I think certain vulnerable groups we must always keep in mind, and the earlier that we give any form of intervention or the benefit from any intervention, the better, because then it prolongs the situation and results in something very severe much later. At the same time, we must not also assume that immediately after a disaster, when any form of intervention like psychological support or counseling services or even medication is given, the problem is done and over with. In fact, it can be prolonged, as we have seen in many cases. Post-traumatic stress disorder, for example, can manifest much later than the incident of a disaster. So groups like this must not be ignored, and therefore the intervention may have to continue for a number of years before a group of people or a society that has faced a disaster can be properly rehabilitated from the psychosocial standpoint. I have been involved in the area of psychosocial rehabilitation. So looking at it from that perspective, the one important lesson that I have learned in my experience in the post-disaster, particularly post-tsunami area, is that never to underestimate the resilience of a particular community, because each culture has its own capacity to heal naturally, actually. And sometimes as mental health workers, we tend to forget this important component. In fact, I think one of the lessons that I've learned is to ensure that we look into the ways and means to harness and to even optimize the resilience that is intrinsic in each culture. And this can result in a more speedy recovery and psychosocial rehabilitation.